All right, so I'm going to jump in and give about a 5 to 7 minute overview, I hope, of renal cryoablation. And so we'll talk a little bit about why we're doing what we're doing, how it stacks up to other options, what the procedure looks like, the recovery, and the imaging follow-up. And so we'll go ahead and jump in. So renal cryoablation is a procedure that we perform typically for a patient who has a solid renal mass or mass in their kidney that is inadvertently found on a scan. And so, for example, somebody comes in with a CT scan, and the CT scan shows an area in the kidney that's not normal kidney tissue. And that is either going to be fluid filled and be a cyst, and that's something that we can just disregard, or it's going to be a solid mass. And if it's a solid mass, then it has about an 85% chance of being something that we think of as precancerous, and that would be called like an oncocytoma or a kidney cancer. And so 85% odds of it being precancerous or a cancer is enough to trigger usually some intervention. And so the three options for intervention for a solid kidney mass would be, other than a biopsy, which could be something where if we're not really sure, we could get a biopsy specimen ahead of time. But other than a biopsy, the three options would be completely removing the kidney, and that's called a radical nephrectomy. Removing portion of the kidney, so let's say the upper 20% of a single kidney, and that would be called a surgical partial nephrectomy, or an ablation. And an ablation is the process of guiding a needle, typically under CAT scan or ultrasound guidance, into an area and freezing it, as the case with cryoablation, or heating it up, as in the case with microwave. And so what we found over the years is that for small renal masses, small kidney cancer, so by small I mean less than 4 centimeters, we call that a stage T1A. So for a small T1A kidney cancer, that the cure rate of ablation is greater than 96%. And so you take greater than 96% cure rate, and as it turns out for these small masses, the cure rates are more or less equivalent than a partial nephrectomy, or to a partial nephrectomy, or a radical nephrectomy. And so as this procedure of ablation has evolved, it has become roughly equivalent, meaning high rates of cure, and it's an outpatient procedure with just a couple needle punctures. And so renal cryoablation for small kidney masses has become really the standard of care, unless the mass is in an area that we just can't get to. And so that's kind of an overview of what we're doing, or at least why we do these type of ablation procedures and how these patients come to us. What we're doing during the procedure is pretty simple. We're using imaging to guide a needle in, or in the case of ablation, multiple needles in, typically with a biopsy first on the same day. And we do the biopsy first, and then we do the ablation at the same time, so that we can then sterilize the area of the biopsy, so we don't worry about the biopsy spreading the tumor anywhere. And so we do a same session biopsy, we guide the needle in place, and in the case of cryoablation, we turn this machine on, and the machine has a cycle of freezing that circulates compressed liquid argon through this needle, and that freezes an area around the needle down to -40, and that's enough to basically give controlled frostbite to the tissue. The good thing about this is when we freeze it, it creates ice. And ice is lower density, and when we're looking by CT, we can actually see the ice form. We can see the ice cover and create a margin around the tumor. And so we can know with a high level of precision that we've got exactly what we wanted, and that we haven't frozen any other structures in the area, and that we haven't injured anything in the area. And so cryoablation is precise and it's safe. The downside is that the freeze cycle takes 10 minutes followed by a 10-minute thaw, and you have to do it twice. So you typically have about 40 plus minutes of freezing and thawing that occurs in addition to the amount of time that it takes to place the needles. And so because of that time, we place these patients under general anesthesia, because it's hard to lay on a table for an hour and a half or 2 hours. And so the procedure itself is really set up with anesthesia for that reason. Microwave for small masses, again, less than 4 centimeters, that are exophytic, meaning that they're hanging off or they're coming out of the kidney in a safe area. is less precise. And what I mean by that is you can't see visually exactly where you're ablating. You have to rely on a chart, but it's a lot quicker. And so we like microwave in certain areas. Even though it's perhaps a little less precise, it tends to be a lot quicker. And so those cases only require needle placement plus a 4 or 5 minute type ablation. And so that kind of gives you an overview of the differences. Microwave and cryoablation in terms of outcome are pretty similar, both greater than 96% for T1A masses. In terms of recovery, the only real risk that we are concerned about, or risks, are damaging something adjacent to the kidney, which is rare, and we usually can avoid just by having good imaging and being careful. And sometimes hydrodissection, where we inject water to displace structures and create a cushion around them. But more or less, the thing we worry about is when we thaw the kidney out, we worry about the thawed tumor then bleeding. And that's rare. We would say that happens in about maybe 1.5% to 2% of cases. Rarely requires transfusion, admission, or an angiogram, but something that definitely worth thinking about, and that's the reason why we recover these patients for a few hours afterwards. In terms of imaging follow-up, the AUA guidelines say that we should get a CT or MRI scan at 6 months, 12 months, and then every year for 5 years, knowing that these tend to be very slow-growing cancers and that they come back typically between the 1 to 2 year mark. One more concept we'll do on a rare occasion is for a T1B cancer, not a T1A, but a T1B, which is between 4 and 6 centimeters. Our colleagues down at UAB a couple years ago published a large cohort of doing ablation on 4 to 6 centimeter tumors. And these tend to be more needles, more ablation, and a little bit more risk of bleeding. And so they found that doing an embolization in angio ahead of time, either the same day or a week or two beforehand, tends to reduce the bleeding risk and also increase the cure rate. And so that has the ability to take a cure rate of a T1B from around 85% into the 90+% range, while reducing the need for an overnight stay and reduce post-op bleeding. And so on occasion, if we end up getting a T1B, let's say a patient who's not a surgical nephrectomy candidate, but they have a T1B 5 centimeter tumor, you may see us do an embolization and then take the patient over to CT to do the ablation. So I hope that gives an overview of what we're doing, why we're doing, what the follow-up looks like, and what the risk is involved. Thanks.